have Dr. Audrey Chun here, who's associate professor from the Department of Geriatrics. Dr. Chun did her residency at Baylor in Houston, and then finished her fellowship in geriatrics here at Mount Sinai School of Medicine. She's received various grants and awards, which have allowed her to pursue her clinical interests in geriatric assessment, medical education, and delivery of different care models in the outpatient setting. She's involved in the educational programs both in geriatric and palliative care, and participates in teaching of residents, med students, fellows, and has been featured in the Frontline documentary Living Old. Has participated in numerous panel discussions on aging in America and its implications, and has been recognized as New York top doctor. So we're very lucky to have Dr. Chun to speak to us about an update in geriatrics. Thank you.
Thanks for that introduction, and thanks for having me talk today on some updates. I have nothing to disclose, but I do want to acknowledge Dr. Roseanne Leipzig, my mentor and colleague. We presented at the American College of Physicians earlier this year an update, and so this is a modified version, and so we worked together on many of these slides. So definitely want to give her credit on that. Hopefully today you'll get kind of a general review of literature in the last year and a half or so that has affected the clinical care of older adults, particularly in primary care. So we really wanted to focus it on things that might affect you in your daily patient interactions with the older adult, and then really ask you to start considering an individualized framework, especially when there is minimal evidence or conflicting evidence in the population you're treating. And today in particular, we're talking about an older adult population. So the first topic is around frailty scores and surgical options. So this seems, why in the world are we talking about this for primary care? It's because where do people get their preoperative evaluations? It's out in the ambulatory practices. And you know, without even any evidence, that an age alone does not kind of predict a person's function and their ability to do well. You have people who are very fit, working, active, exercising at the age of 80. There are other people who might be a little bit more vulnerable. Maybe they have some cognitive impairment, but physically pretty well. And then those who are frail at the same age, who are both cognitively and physically less able. So what exactly is frailty? We talk about it as a decrease in the physiologic reserve. And as a result, you have diminished resiliency, you have less ability to adapt, and you're more vulnerable to stressors. And as a result, all the consequences that come around that you think about with aging and frailty, falls, disability, delirium, cognitive problems, social isolation or withdrawal, and even increased risk of death is associated with frailty. So what are frailty measures? There are a number of them out there, but they're really attempt to quantify what we kind of know by looking at a patient in a way that might be useful. And by using these frailty measures, we know that those who are more frail in non-emergent and in emergent procedures, surgical procedures, are more likely to have complications. They're more likely to lose function after their procedure. They have longer recovery, longer length of stay, and increased mortality. So these authors were actually trying to figure out with ambulatory surgery, and specifically with hernia, breast, thyroid, and parathyroid surgeries, is frailty associated with perioperative morbidity? And they actually looked at mortality, although you would hope that the mortality rate is low with these ambulatory procedures. So this was actually the NSQIP registry. So a huge number of patients, all people going through surgery and participating in the registry, are required to put in this information. So it's a giant registry, and they looked at 140,000 people who were getting these ambulatory procedures. They excluded anything emergent if you didn't need anesthesia for your procedure, if you had sternotomy requirements, because that clearly is a different kind of case than what they were looking at. They looked at 30-day mortality as well as length of stay. Those are things that are important to the surgeons and to our hospital administrators. And they looked at a whole host of potential perioperative outcomes, ranging from pneumonia down to UTI. Although they included superficial surgical infections and UTIs, those weren't considered a serious complication. Although I would argue for the patient and for their family, that would be potentially, and in an older adult, a serious complication. So what did they do? It's all registry based. It's not related to someone, proactively looking at the patient and doing a functional. So this functional assessment. So these were all things that were related to the database. They looked at these 10 factors and basically counted up how many of those 10 factors you had and divided it by level. And depending on what your score was based on that, how many of these factors you have divided by 11, you were categorized as having low, intermediate, or high frailty and high risk associated with that. The most common complications are those that you would expect. So superficial incisional, they didn't consider that to be serious. Deep incisional, or having an infection within the organ or within that deep space. Pulmonary complications, pneumonia, having atelectasis, hypoxia, sepsis, and UTI. And only the bolded ones were considered serious, but I think we included that in our list just because they affect perioperative and postoperative care. So as you can see, the higher or more serious your frailty or risk score was, it did actually predict whether or not you had complications. So you were much more likely to have complications, about 7% of any kind of complication and about 4% of serious complications, the higher if you're in the highest risk group. That was unadjusted, but with age adjusted, as well as sex, race, ethnicity, the type of anesthesia, whether you were a smoker or not, you could actually even see that for those in that highest group, you were very likely to have a complication compared to if you had a lower score. And that seems to go across the board regardless of whatever type of surgery they were looking at. Although you can see that with breast, it seemed to be even higher compared to the other ambulatory surgeries. There were limitations. This is entirely from an administrative database, so there's no way to know exactly what the function of a person was. And the outcomes were limited only to 30 days, but I actually don't think that's too much of a limitation since these are ambulatory procedures and you would hope that complications aren't extending beyond that period. They had no data on readmissions, although they did have data on the length of stay. And it was primarily using comorbidities, not so much functional status, which is what we really focus on as geriatricians. But I think there's some important take-homes for those of you seeing preoperative patients in the ambulatory setting. That frailty is associated with worse outcomes. You can argue about the percentage or how severe those things are, but it is worse outcomes. And it's important to evaluate that using some sort of a validated tool. I don't know if they'll have access to the slide sets afterwards. Yeah, perfect. So in there, I'm not showing all the different frailty scales, but if you look at the slide sets later, within it are about 4 or 5 different scales that you could use that are validated and fairly easy to use. So there are a lot of them in there. So I encourage you to consider that within your preoperative evaluation, so including the typical pulmonary cardiovascular evaluation, particularly in an older adult, doing an assessment of frailty to help counsel the family and also to predict if a person is more likely to experience complications than someone who is not frail. All right, so go, yeah.
Sorry, I don't know.
Please do.
Sure. Topics, but just a quick one on that. So the measure that they used for frailty in that study looked to be more like a measure of multimorbidity as opposed to what I usually think of with frailty. Like, muscle strength and functional capacity. So is there any reason why that one was chosen?
No, I think it's because it was the information they had in the database, and they did include functional status, but it was self-reported or whoever filled out the form. So it's unclear how much that reflected the actual functional status of the patient. So it's not a true, and that's a great point, that it's not a true measure of frailty, and that is certainly one of the limitations. But there were measures that are associated with frailty. All right, so we know physiologically that male testosterone production decreases with age. Sometimes menopause. And there are all sorts of things, horrible things associated with low testosterone, low T. So constant fatigue, maybe an increased risk of dementia, depression, osteoporosis, increased fat tissue, low libido. It's a horrible thing. And then look at this person, optimal testosterone, he's doing great. And the reason why we brought this out is because there's a lot of direct-to-consumer marketing of testosterone. Low T is like the buzzword, and a lot of people are coming in, particularly people who are fairly functional, and they're trying to figure out how in the world can I stay as good as I can be and feel good about that. And so it's a question that comes up. Can't I take, I read about this, I brought this, I saw the commercial. So there was actually a number of T trials to help us answer this question as to, is it even a good thing. And I have to say, I kind of changed my mind a little bit after looking at the data. I thought it was all bunk, but there might be a little something there. So who were they looking at? Men over 65 who had a documented low testosterone level. And they were eligible for at least one of these T trials that looked at a few different areas that could be associated with low testosterone. It was placebo-controlled. People were followed for a year and on therapy for a year, and they were given a pump of a 5% gel, of a 1% gel, 5 grams daily, and the goal was to increase it until they had the testosterone level of a normal 19 to 40-year-old man. So they looked at sexual function, physical function, as well as vitality, with both reported, self-reported, as well as a validated scale for each of those measures. So looking at sexual function, the people who could be included were those who reported decreased libido. They also had to have a willing sexual partner, where you were excluded if you had severe PVD. The physical function, you had to have some self-reported decreased ability to walk. And for the vitality trial, it also looked at self-reported energy, as well as a validated scale on fatigue, as well as walking speed. Now, you weren't exclusively in one trial. There were some people who were in multiple arms of this, and they would ask these questions. So, but several hundred were at least in each arm. And so what did it show? For sexual activity, in the validated tool, to ask people had a slightly more sexual activity if they were using testosterone than if they were not. And their actual reported sexual desire or libido was actually greater in those who were receiving testosterone than those who were receiving placebo. When you looked at walking ability, it was not statistically significant, but there was a trend towards some slight increase in gait speed in those who were taking the testosterone or using testosterone compared to placebo. And the self-reported change from their baseline, do you feel like you can walk faster or more vigorously than you could before, was actually reported higher in those who were receiving testosterone compared to placebo. Vitality as well, it was not statistically significant, but there was a slight increase in people who were receiving testosterone in the validated tool to measure vitality. But when you ask people, what's your energy level like compared to before, those who received testosterone actually reported that they felt more vital. They felt like they had more energy. And when you asked about overall health, the same trend kind of continued. People who were on testosterone reported that their overall health was better on this treatment compared to those who were in placebo. So what are the benefits? In sexual function, there might be a moderate benefit. There seemed to be slightly more libido, improved libido, and perhaps more sexual activity compared to before. There was not a significant change in physical function, although self-reported there might have been. And in vitality, again, not a significant change in the scores, but all the participants did report an overall improvement in their health, their reported sexual activity, energy level, and walking ability. So it's not without consequences, right? There are always potential side effects to treatments. And in particular, the one that was most significant were an increase in a PSA as expected in people who were being followed. And there are lots of other potential adverse effects of being on testosterone therapy. The most serious being, increases in hemoglobin hematocrit, heart failure exacerbations, risk of stroke, risk of MI, risk of cancer associated with testosterone use, and then other things which are perhaps less important, but for the patient may be significant. So the caveats to this, remember it was a younger, older group that they were looking at. The average age was 72. Even though they were enrolling people over 65, it was a little bit of a younger age cohort. They were looking at 90-year-old people with low testosterone level. They did have a low documented serum testosterone, so it wasn't just symptoms. They had to have a low testosterone level as well as symptoms. And a number of people were excluded. So people with significant coronary disease, out of control blood pressure, if they had depression or cognitive impairment, or conditions, if they had underlying prostate cancer, for instance, it would be an inappropriate therapy for them. So that already moves out a lot of people that would be appropriate for this. And it was only a year that they were following out, so who knows what would happen if you continue therapy for longer. But You might consider this in people who are relatively healthy, who have low testosterone levels with symptoms. You wouldn't do it just randomly screening a testosterone, but if they described any of those symptoms, and particularly those who are complaining of sexual dysfunction, that they may have some improvement, at least in their self-reported sense of their symptoms. Probably, since we don't have the data to do no more than a one-year trial and to reassess whether that's a benefit, and to think about stopping, and you would definitely have to be monitoring certain conditions, to make sure about safety. Questions? All right, so dementia prevention. This is another thing that every week there's something in the New York Times telling you that this will cause dementia or it will save you from dementia, and I typically will get a few calls or emails or my chart messages asking whether they should be on it or whether they should stop something as a result of that. So here's for the group. What percentage of people over 85 have dementia? I think it's 10%, 20%, 30%, 40%, or 50%? 20%? That's like a resounding, all right, that's pretty good. So it's a kind of a trick question because it kind of depends when you were looking at what decade. So about 20% if you were looking at the time period between 2008 to 10, and about 30% if you were looking at the time between 86 and 87. That's like a 30% decline in 20 years. Like, what is happening? So there are some speculations. It's hard to know exactly, but this trend has been seen again and again in different industrialized or developed nations. So in the United States, in the Netherlands, in a lot of the Scandinavian countries, there's actually a lower incidence of dementia compared to some of the others, even though worldwide we still have a big problem, and 30% is not a small problem, or 21%. But it's thought to be possibly related to our better treatment of cardiovascular risk factors and perhaps education at a younger age, getting better educated at a younger age. So we know that there's still a high prevalence, and it's important for us to consider. And I think for this group particularly, you're treating people younger than I think by the time they get to me, there's not a lot of prevention is related to brain health that can be done, but the population that you're treating, potentially you can make a huge difference. And we'll talk about that with the Lancet review. We're unsure exactly what the optimal treatment or plan is to prevent cognitive decline, but lots of things are being touted out there, right? Supplements, exercise, brain exercises, and different medications. So in the annals, in the last year, there were actually a very robust series of reviews that used the same methodology that's needed in order for USPSTF recommendations to be made. So it's very rigorous. Only randomized controlled trials are included in this, and only those of the highest quality are included. So it's a very restricted review of the evidence, but it's an excellent review and methodology. There was also a Lancet Commission report, and this actually included a slightly larger body of evidence, not only randomized controlled trials, but also observational trials. And so we'll go through each of the areas that they looked at. So the first area, the first review is around physical activity. Does any sort of exercise program actually improve or decrease your chances of having dementia? And the bottom line, unfortunately, was that it was insufficient evidence that short-term, single-component physical activity interventions prevent decline. But there were a lot of cognitive trials, actually, that showed favorability compared to people who were getting placebo or kind of just the gentle stretching exercise component of it. And so it may be, and we'll talk about the limitations of all of these, it may be that a single intervention for 10 weeks is not the thing that's going to prevent dementia, right? It's got to be something a little bit longer, and you have to follow people for a longer period of time. So a single short-lived intervention hasn't been shown to significantly alter the course. What about medication? Everyone wants a pill. Why can't I give a pill to prevent my memory from getting worse? So this one had more trials included, but a wider variety of medications. These medications included those specifically targeted towards dementia, all the way to cardiovascular medications and even hormone replacement. So just as a summary, basically the bottom line was nothing seemed to prevent anything, but acetylcholinesterase inhibitors certainly did not change the course. Antihypertensives did not seem to show actual prevention of dementia, but again, many of the trials that we're looking at weren't primary outcomes for dementia. Same with diabetes, with statins, with nonsteroidals, when looking specifically at trying to prevent dementia. In hormone therapy, with our Women's Health Initiative and subsequent trials from that, there might be an actual increased risk of MCI and dementia as a combined outcome using estrogen alone. And with the other hormonal agents, nothing significant. So the bottom line is that current evidence really doesn't show the support of using any of these medications for cognitive protection. You may argue about once you're already diagnosed with dementia, whether any of these things are appropriate, and I would argue that that evidence is not robust either, but certainly not for cognitive protection. All right, so what about vitamins? I know I read the red yeast or the ginkgo or whatever, and it's really gonna help me. So here too, they looked at 38 trials and again, a wide variety of supplements. Anything from omega-3 all the way to beta-carotene and multi-supplements for brain health were evaluated. And again, as expected, insufficient evidence to recommend any over-the-counter medication to protect cognitively. So things are not looking so great here. Well, what about brain exercises, right? So here too, they looked at 11 trials where they looked at different cognitive programs. Most of them were computer-based, where you tested your reflexes and memory and trying to match numbers and letters and things like that. 5 of them actually also enrolled people with MCI, and the others were with normal, healthy brains. And there was actually no significant improvement in overall cognition, but you got really good at the thing that you were being trained to do. So if there was a driving test, you could do the driving thing better. So I wouldn't say that this is a good intervention to necessarily prevent decline, but if there's a certain area where people are having difficulty, you can improve your cognitive ability in that one domain that you're being trained on. And so that might be the takeaway from that, but it's certainly not globally going to improve your cognition. So that was disappointing. There are a lot of limitations to this. Even though the methodology was extremely robust in the way that they were looking at only those with randomized controlled trials, that's also its limitation, because we may be missing important information that was found in observational or prospective trials. There was also kind of inconsistent cognitive outcomes. So even though they were looking at dementia and they were looking at mild cognitive impairment, the way they measured those things were different in all of the trials. So it's kind of sometimes hard to compare apples and oranges. And I think this is the most important point, is that the time frame of the studies may not have been long enough to actually measure outcomes. If we're talking about prevention of something that is decades long in the making, maybe a trial of 6 months or 9 months is just not enough to know if it has an effect when the follow-up is only that period of time as well. So the Lancet commissions did try to take a broader look. This was actually a commission that was to look more broadly at dementia. So both with prevention, but also once you have dementia, what are the best areas to treat and to support families and things like that. So I'm just going to concentrate on the prevention area, but it was, hundreds and hundreds of pages long, going through all the different areas of dementia care. They too were fairly rigorous and only including evidence-based approaches, but they were looking for things that were actually doable and scalable, that were high value, that maybe could actually impact care. So they kind of added that other layer of having some clinical practicality to the evidence that they were reviewing. So what they found is that it's probably a lifelong path to dementia, and that maybe about 35% of things that happen along the way are things that we can actually impact. So yes, there's the genetic component. It is what it is. Whatever is in there, we're not going to be, probably at this point in time, at least with our current technology, we're not going to be able to impact that. But there are so many other things that begin very early in life from elementary, middle school, high school. So the level of education that you receive in your lifetime seems to affect your risk of having dementia in life. And again, as an internist, we can't affect how much education a person has, but being mindful in our broader advocacy, it's something to really consider in trying to keep our population healthy. But all these other things are areas in which you do have a significant impact in being able to evaluate and to manage the things. So education kind of early in life, maybe we can't change that, but it's something that is modifiable as a society. There are other things in kind of midlife to later life, hearing loss, hypertension, obesity. These are things that you all are counseling every single day and trying to have people live a lifestyle that can support that and to manage them with medications. Encouraging smoking cessation, managing depression, helping to people to recognize the importance of different kinds of physical activity, avoiding social isolation, obviously managing diabetes. That all of these things seem to have a cumulative effect and increase the risk of developing dementia. And so this idea that it's not a single intervention or an easy fix or a silver bullet or a magic bullet, as one of the editorials was commenting on, that it's actually a lifelong approach to dementia prevention. And so we may never have a trial that says this is the thing that's going to prevent it, because how can we get a trial that goes from birth all the way to dementia? It's a near impossible endeavor, but looking at the evidence, it seems that these things are associated and potentially modifiable. So I really encourage you all to think about not only the things you're doing on an everyday basis to prevent heart attacks and strokes and complications from diabetes, but that it also has a profound impact on their brain health later in life. All right. So, vision and hearing correction, I think that falls lower on our list sometimes when the blood pressure is 180 and their A1C is 13, and we're like, we'll get to that at the next visit. But in fact, vision and hearing correction is probably equally important as far as cognitive health and trying to protect the brain. So if you can remember to add that to the list of 100 things you have to do at a visit. Obviously, controlling vascular risk factors, avoiding medications, encouraging physical activity. We can't help them necessarily avoid social isolation, but we can encourage resources or refer to social work to help with those sorts of situations. All right, so for the last half of this, I'm going to go through some controversies that affect you. We're going to spend the rest of the time talking about hypertension and statins in older adults, and I don't know if I'll survive it or not. There's yes.
That's a really good question. Of
course.
Dementia. We try to explain to our patients about all these issues, but yet they come with these preconceived notions, and secretly they are going to take some medications from whatever they hear from their friends.
Yeah.
The studies are mixed. So if I could compromise with them, say, don't take this herbal, if you take this, what can I give them in place? Like something that's a little bit more safer. That's because the studies are so mixed. Has there been any efficacy on Ginkgoa, omega-3s, vitamin E?
No. So vitamin E at one point at Mount Sinai had been shown to be positive, but it was debunked with other, so for every positive study, you have 2 or 3 negative studies. So I think there really is no evidence to support that use. I will say for the majority of these supplements, the safety is, the harm is not great if they're not taking mega doses and 100 of them, right? So if you said, okay, if you really believe that this ginkgo is going to help you at a low dose, maybe compromising in that way, I don't think you're going to get a lot of benefit from that, but I don't think you're going to be harmed by it. With the caveat that a lot of these do interact with medications that we prescribe, and it's hard to even know the depth and the breadth of that. You have to look up every single one of those interactions. But just common ones, vitamin E and ginkgo have been associated with increased risk of bleeding, and so many of our patients are already on aspirin or anticoagulation for other reasons that I would definitely try to steer them away from those medications that might increase their risk of real harm. But otherwise, that's the compromise that I usually will make is, I don't think there's benefit. I don't think there's harm. And if you really believe this is helping you, then, so be it. But I don't endorse it. I don't recommend that you're doing it, but I appreciate you telling me about them because they can have important interactions. So you don't want to shut the door for them to never tell you that they're taking extra things. So I think it's important to collaborate and not dismiss, but also be evidence-based around that. Other questions, comments? Terrific. All right. So this is a framework that I was talking to you about that I hope you start incorporating, especially with your oldest adults, when there is perhaps less robust evidence of benefits and perhaps some harm related to the population we're talking about. To really think, how long does this person have to live to actually receive the benefit? If I don't think their life expectancy is 5 years, then maybe something that will take 4 years to gain benefit doesn't make sense for them anymore. How likely are they to benefit? Are they in the population that would actually benefit from this therapy? And then how likely are they to have harm from this, and how quickly will they have harm? So if something can benefit them in 3 years, but it can harm them in 6 months, that's a very different kind of balancing of whether a therapy is worthwhile in a person who may have some limited life expectancy. And then all of that obviously has to be within the context of the individual person's goals, as well as their function and the other conditions that you're treating and the medications you're treating them for. So blood pressure targets for elders. I feel like whiplash has gone on this year. So we know that, I don't have to tell this group, uncontrolled hypertension is bad. It's associated with very bad outcomes. And in fact, older adults are at higher risk of these bad events. They're at higher risk of having stroke and heart attack and peripheral vascular disease. And so treating these conditions aggressively, in fact, may be of greater benefit for them because they're at higher risk of having these bad things happen. At the same time, they're also at much higher risk of having the bad things happen with the therapy that we provide to them. So particularly around blood pressure medications, they can have orthostasis and falls. They're more likely to maybe have electrolyte abnormalities or even kidney changes, renal changes related to that. And syncope is associated with falls is always a concern that we have. And I'm sure you all have never had the person bring in the medications that look like this, but this was an actual patient brown bag. I was very happy that they brought their medications with them, but there were duplicates, there were medicines that were terribly old, there were things that were prescribed by 4 different providers. It was a total mess. And so to add, to say your blood pressure's out of control, here's one more medication, I mean, clearly we have to consider what we're doing in that circumstance. So I think in that case, picture's worth 1,000 words about potential harm. So in 2014 was the last JNC report where they gave guidelines on hypertension management and goals, which I think most of us have been following. They were simplified compared to previous JNC. So it's basically 140 over 90. You really wanted to try to get to that. And then they kind of passed on that responsibility for developing these guidelines to the ACC and American Heart Association. So last year they came out with a beautiful guideline that's hundreds of pages long with lots and lots of caveats of what you should be doing and what you shouldn't be doing. And then interestingly, later that year, the ACP and the American Academy of Family Medicine actually specifically set out a separate set of guidelines saying that we don't actually endorse everything that the ACC is putting out there, particularly for older adults, for people over the age of 60. And we think we should still follow the JNC 8 guidelines based on that. So then, what are we supposed to do? There's like back and forth around all of these things. So what were the actual changes? So this was the ACC AHA guidelines from 2017 that basically, it wasn't so different from JNC 8. They kind of changed pre-hypertension to stage 1, and they included a risk calculation. So if you had a higher risk of coronary disease or cardiovascular events, then they recommended that you treat at stage 1 hypertension, or what was previously called pre-hypertension. And then everyone, in the same way that JNC 8 had recommended, that everyone really should have that goal of 140 over 90, less than that as a therapeutic goal. They also went through multiple different populations, but the bottom line was even for people over the age of 65, they recommended actually a lower threshold or blood pressure goal because of the increased risk of cardiovascular events. So if you look through the list of the special populations where they were doing it, it was basically you had higher risk of having cardiovascular events and your calculation was greater than 10%. And that's why you got put into that lower goal bucket. So all right, so instead of 140 over 90, now I have to do 130 over 80. And this was primarily based on outcomes from SPRINT, which was published a couple of years ago, maybe now 3 years ago, and showed a pretty dramatic. They actually had to stop the trial because this was specifically targeted at older adults and doing intensive treatment with a goal of less than 120 systolic compared to usual care, which was for a goal of less than 140. And you start seeing in about 1 or 2 years that they start separating out. Those who received intense treatment were less likely to have adverse cardiovascular events and even death. And so the trial was stopped prematurely because it was pretty dramatic as far as the difference in outcomes. And people would argue, it's because you only had really fit older people that you had in this trial. But no, they actually saw this difference in people who were fit, less fit, and even frail. So, the American College of Cardiology, and there was a caveat that a person who was the lead investigator of the SPRINT trial was also on the guideline panel for the ACC, really took this into account and said, gosh, we need to save lives. We've been undertreating older adults. It's kind of a case of age discrimination, and we should really be targeting that. Well, an important caveat from the SPRINT trials, they didn't include people with diabetes. And we have a fair amount of data that's been analyzed and reanalyzed and republished again and again from ACCORD. But in 2010, the data suggested that with intense blood pressure control in people with diabetes, there was actually not a difference between those who were treated to an intense target versus those who were treated to the usual target. And so maybe there are certain populations that don't follow what happened in the SPRINT trial. And they also reported on the adverse events, which were more likely to occur and statistically significant between those who were treated intensely versus those who were not. So more likely to have problems related to low blood pressure, having acute kidney injury related to being on antihypertensives or lower blood pressure goals, and electrolyte abnormalities related to that. And this is where the ACP and the AAFP came out. They said, you had this incredible evidence-based review, and we appreciate that, but I think you only looked at the benefits, and you as a panel didn't take into account equally the potential harms for this population. And so as a result, they actually rejected the guidelines from the ACC and the AHA and said, we really feel like the guidelines that were presented from the JNC8 should still hold based on the evidence that we also reviewed, and also including the potential for harms. And so in this case, for those who have a blood pressure or the goal for less than 140, it was fine to keep it that way. You might consider that treatment for people who had higher risk of cardiovascular events. And in fact, if they didn't have that high risk, that 130, 150 as a systolic goal may be okay. So what are we supposed to do? So generally, I think we should follow those guidelines, but I would say that we stop and we reject permissive hypertension. So I am 100% guilty of this as well. Someone comes in and their blood pressure is 143 over 90. It's close enough, right? It's really, really close. So I'm sure if I check it 3 more times, it's going to be below that, and I just leave them alone, right? Because this is just, I don't have time to check it 3 more times, so I'm sure it would do that, and I think it's fine. I think we have to kind of reject that these really, we should really be pushing to those actual goals, because we do have data, we do have evidence that getting them to lower blood pressures. And I would say a caveat to the SPRINT trials is no one got to below 120 systolic. So the vast majority of the people who were in the intensive group got below 140 as a systolic, but they didn't get below 120. So it just kind of reinforces to me that these goals or these guidelines are ones that we should be really trying to achieve, and not being as permissive as we sometimes will get, because it's hard to think about it. The SPRINT investigators commented that most people did not feel overly burdened with taking an additional medication for their antihypertensive regimen, but I would argue, like when you're already on 30, maybe it can be more burdensome. Exactly. So it's a hard thing, but I think that was my takeaway, is that if I'm going for any of these ones, that I really have to try to get to those goals. And so especially if they're at higher risk for cardiovascular events, that 145 is not good enough, that we really want to try to push them to less than 140. And then if a person is fairly robust, if they don't have a lot of multimorbidities, that maybe you might consider a more intensive treatment regimen for them if they're not getting dizzy with an additional medication or pushing a dose of a medication, that might be appropriate for them. But you want to take it in context of that person's life expectancy, and you want to take it into the context of their actual risk of having an event. And you may consider whether or not they have diabetes into that mix. So I'm a little bit wishy-washy, but my big thing is like try to get them at least below 140 if you can, and kind of do away with that permissive, a little bit higher than goal hypertension. Yes.
So, thank you. This is really critical and very controversial. And we've had Larry Craykoff in here to help us with this. So, I guess with regards to goals, so I thought JNC8 for older patients, that's for the 150, not the 140.
Correct.
That took into account the cord.
Correct.
So if you're going to try to fold it all together, I'm not sure that you should necessarily shoot for 140 right now. If you're paid, like if the example, the 143 that you were talking about, if you're kind of in between.
Right. So you're exactly agreed. So the 150/90 would be kind of your general for an older adult population. And so your 143 would be okay. And actually that's a standing blood pressure. So you have to, that's the caveat with that. It's a standing 150/90. But that I would say for those who have already had cardiovascular events or are at increased risk, that I would say we really it's important for us to go for that goal, recognizing all the different caveats. Obviously, if they have harm, if they're getting dizzy, if they have terrible orthostasis, then that's not the goal for them, and we have to individualize it. But for those who are not having those kinds of circumstances, I would argue that for cardiovascular health, and especially when we're thinking about this dementia risk spectrum along the line, that I think we owe it to them to try and to really explain to them why it's important to try to get to that goal. But for the average risk, older adult, they're 80 years old, I don't think 140/90 is probably my goal for them. Is 150 is a reasonable one.
And if that risk is and if they have a history of CAD and the risk is because they're diabetic, then how do you, where the
I don't have the answer to that.
The thing is, like, you have some 60-year-olds that are like super functional, like 40-year-olds, and
Yeah.
you may want to be more aggressive with them, right? Versus some 60 or 65-year-olds that
It's low
really
function.
are like an 80-year-old because
Yeah.
they have so many comorbidities, even if some of them are cardiovascular, that they may not have that much life left. So why be that aggressive?
Exactly.
So I think that's what's missing from all of this. And it's very easy when you have like an age, because you can just look at the number and do this, but you miss that nuance of like, are they a sick 60 or are they like a healthy 60?
100%.
A sick 80 versus a healthy 80.
And so that's where I feel like that framework where we have to think about the person in front of us and really what's their risk, what's their ability to kind of manage the plan that we're talking about, and be realistic about that as well. So it is nuanced, and that's why it's in this controversy section, because I don't have the answer for every situation, but I do know that we're still treating people, and we have to have something that we're going through and helping to guide us.
We looked at, I know in Internal Journal Club, a review, or it was a cohort study, but they looked at all the patients that Accord who fit sprint criteria, and all of them benefited. So the thought was maybe the Accord trial wasn't catching those who have the cardiovascular risk, but they took everyone who was in Accord who would have fit sprint, and they all benefited.
And they seem to benefit. That is true, because I did see that subset analysis.
Definitely risk stratifying them.
Many of whom were diabetic.
All of them are
All from Accord.
Accord was all about
patients
Yeah.
who would have fit.
So it's hard because we always consider diabetes as just a cardiovascular risk, like equivalent, right? But in reality, there's risk. There are people who are at lower risk within even that group. And so, but practically speaking, how are we going to risk stratify to be like, are you in the low risk diabetes group or are you in the high risk? I mean, this is, it's beyond what you have reasonable time for and to consider. So I think we treat the individual, know our evidence, and really try to improve their care in the best way that we can, but it's a complicated thing, and it only gets worse with statins. So I'm going to delve into that so we have time for questions. Is that for secondary prevention, I think there's no doubt that the evidence is robust, regardless of your age. You had a heart attack, you had a stroke, you had an event, that a statin is good for you to continue unless you're getting horrible harm from the medication, terrible side effects, and can't tolerate it. But primary prevention is where we get into a little bit of trouble, especially as people get a little bit older. So some of this is not in the year and a half. We're looking at trials and things over the last several years. And if you look at guidelines in clinical practice, for the younger, older people, it's still recommended for primary prevention. So it's good evidence, it's strong evidence into your 50s to your 60s, and then you start getting into your 70s and 80s, and either there's insufficient evidence or lack of evidence, or no people were studied in their 80s, and so it becomes a little bit harder to recommend for primary prevention. I just want to kind of keep reminding we're talking about primary prevention here. So for all of these things, for those with risk factors, the recommendation up to about 75 is really, you probably should be treating them with statins. But if you think about who gets put in that risk calculator, like what the different calculations are, by the time you reach older age, you make it, right? Like you have a high risk of cardiovascular events. So that it's not useful because 100% of the people are high risk by age alone. So this becomes less useful for us. And so, there's less risk stratification the older you get because of the way the calculator developed. So the question is, are we over-treating people for primary prevention with statins, or are we under-treating them? And we don't actually have a clear answer, but there are some data that suggests that yes to both. We're probably under-treating some people and over-treating other populations. So in primary prevention, the evidence for over-treatment, is there a way that we can actually identify a group that won't benefit from statin therapy? Are there some people that were like, we know that you're not going to benefit from statin therapy at 80 years of age, so we're not going to prescribe a medication that you're not going to benefit from? So this study, which is a couple of years back, actually was looking at the coronary artery calcium scores, which again, if you were at Grand Rounds early this week, who knows whether we should be using, we don't know what to do with the information, but it is possible to risk stratify from there. So with scores of 0, you're very unlikely to have a cardiovascular in at least the next 3 years, as opposed to those with scores over 100, where you're much more likely to have a cardiovascular event. And so maybe if there's a good way and an easy way and an inexpensive way for us to risk stratify if someone comes back with their cholesterol being slightly elevated, maybe we can spare a person who would not benefit from therapy by saying, your risk is quite low. I don't think you're actually going to gain benefit from taking this medication. And there's still other people who would benefit, and we should kind of take that into account. But to feel comfortable saying your CAC was 0, you're unlikely to have an event. Probably you're unlikely to benefit from being on the statin, maybe. So lots of limitations to that study because some of them were actually taking statins, so who knows, maybe that was protecting them. And of course, there's kind of selection bias, so a lot of people who are agreeing to come in there and getting a calcium artery score, they are healthier and they have different lifestyles and they're seeking different opportunities, so it may be some cohort bias there. They looked at revascularization as an endpoint, and it was kind of only a short period of time. It was only about 3 years. And so maybe if it was extended longer, you might have seen a difference. But of late, that warranty period of that calcium score is anywhere from 5 to 15 years. So you would think that if you're low risk and, the person's life expectancy is only about 5 to 10 years because they're 85, maybe that will help you make a decision. So what about undertreatment? Maybe we're biased against older people and we say, gosh, they already have so many medicines, forget it. I'm not even going to think about a statin for primary prevention. So is there real evidence of benefit for people who are over the age of 75? There are a bunch of, my little things are not going. So I have these little circles that are going on there that were supposed to go along there. So if you look at all-cause mortality, heart disease and stroke in an older cohort, there was actually not a tremendous amount of benefit that was seen in that group when we're talking about primary prevention from data that we do have. There's problems with all of this because it's post-hoc secondary analysis of that all had data, so it was like re-digging through everything again. But there were a fair number of patients, over 2,000 patients, nearly 3,000 patients, and they all had risk factors that looked like our patients who are going through there, and they were not taking lipid-lowering agents. They looked at people who had were not taking lipid-lowering agents, and they looked at all-cause mortality as well as other coronary events. This one, they followed them a little bit longer. And it's interesting because it looked like the cumulative event rate was maybe perhaps slightly higher in the pravastatin group compared to the usual care group. Although the cumulative event rate, perhaps if you followed them a little bit longer, may not have been. All-cause mortality actually was about the same, but slightly lower in the CHD group for those who are getting statins after about 3 years. So time to benefit may have been about 3 years. So, here's where I said that. So what are the risks of statin use? Why do we even care if everyone can benefit or potentially benefit and there's no harm? Then why not just do it? Well, there are risks of using statins. So there's risk of functional limitation in older age, is shown by muscle biopsy as well as by functional tests, that people who are older and more frail and taking statins are more likely to have functional limitations. There's a possible association with cognitive impairment. There's a diabetes association, lots of drug-drug interactions. Obviously, the risk of muscle problems and rhabdo. Along with that, there's not a higher risk of cancer. That's good. And we know that stopping statins during an acute event is bad, so we really don't want to do that. But it's safe to deprescribe in those who might have coronary artery disease. So here's our take-home points from this. If you're less than 75, probably you should be on a statin for primary prevention. I think there's robust evidence to support that. If you're over 75, we have no idea. You might be able to risk stratify. So if you know this person might be at lower risk because of either their risk profile in a number of different ways or through a calcium score, then maybe that person doesn't need to be, and you can feel pretty good about not starting a statin in that person. But again, looking at the person in front of you, if the person has limited life expectancy and the benefit is going to be 3 to 4 years down the road, then primary prevention statin really makes no sense at all. And for those who are wondering, because I get this a lot, patients have been on a statin for a while, is it really helping me? I think I have muscle pain for it, or I'm weak, and I think it's because of my statin. The trial off is fine, right? To take them off and to see is not going to magically change their benefit or their risk of developing coronary disease after a 6-month trial. So you might consider a trial of that therapy. So I hope that you got a little flavor. Each one of those topics we could have gone over for an hour. It's a very quick review to go over these areas. But I do hope you take into account frailty when you're doing your preoperative evaluations. I think that's an important caveat and important in counseling patients and families about what can be reasonable expectations. You might think about testosterone for a younger, healthier group of people with symptoms. That dementia prevention is probably a really long-term thing, so all the work that you're doing is super important in trying to prevent cognitive decline and cognitive issues in our population that ages. I don't have all the answers for blood pressure targets, but I think it's reasonable to think of the 150 systolic generally and 140 systolic for those at higher risk. And for statins in primary prevention, I'm not sure that there's a lot of benefit in the oldest old with limited life expectancy based on the data that we have, and that there are subgroups that have benefit and probably subgroups that have less benefit in the oldest age groups. So, like 2 minutes for questions.
So on the dementia one, you have listed avoiding medicines that are bad for the brain. So is that going to be like the PPIs and maybe your statins?
It could be. So with the PPIs and the statins, those have been associations, and they've not been like kind of cause effect. But there are associations, as are hypnotic agents, as are certain antihistamines, like the sedating antihistamines, so benzodiazepines as well. I actually find when patients are demanding, I need to have my sleeping pill, I was like, wow, that these sleeping pills have been associated with dementia, and they're like, I don't want a sleeping pill. I got, so it helps me in some ways, but those are things that you really want to try to avoid. Exactly. So the Beers criteria, those are not all because of cognitive things. Some of them are related to function and physiologic changes related to renal function. So they're good to think about carefully before prescribing. But yeah, those are the ones that I would be cautious of when we're thinking about cognitive neuroprotection. But it's sometimes helpful in the conversations that you have with patients. It doesn't always work, but. So I've had people too. I'd rather be demented and sleep. Like, okay. Any other questions?
I have a bunch of patients who are older who their systolic blood pressure, like their pulse pressure is really big. And I know that's
Yeah.
get older, but their systolic is like 160, 170, their diastolic
50,
yeah,
40.
so
Yeah.
What's your approach?
So that's a more complicated question, because when you look at all of the trials and look at the diastolic pressures, the evidence is kind of all over the place. So in fact, the recommendation that the ACC had about looking at both systolic and diastolic pressure actually doesn't hold water for older adults at all. And I think in reality, the people with the lower or the wide pulse pressure and the low diastolics, those are the ones that tend to have like syncope and tend to have a lot of orthostasis. So while I wouldn't look at it as a blood pressure goal, like your diastolic is too high, so we would need to treat, I would use it in thinking about whether or not it makes sense to push that systolic a little bit lower. If there's a wide pulse pressure, they probably are more likely to have harm than benefit from that intervention or trying to push to that goal. So that's a great point and comment. Yeah. I think that's supported by kind of multiple trials, that's where the harm often comes from, is the low diastolic. Thanks for your time.